Good morning, all. I'm Dr. SRUTHI B, practicing periodontist and implantologist. I completed my post-graduation from Royal Dental College, Palakkad. I feel privileged to present Section 6 of Reading Club based on Misch Contemporary Implant Dentistry in connection with International Implant Summit 2026. Let's begin with Chapter 26, Basic Surgical Techniques and Armamentarium. Flap design. Surgical flaps are made to gain access to a surgical area or to relocate tissue from one area to another. Over the years, the mucogingival flap design used in oral implantology has changed dramatically. The use of technology has allowed for more accurate and ideal placement of implants and bone grafts, along with better techniques for handling tissue and preserving blood supply. In the early years of oral implantology, most surgeries were completed with an aggressive full reflection of the surgical area, including full releasing incisions that traumatized the tissue and compromised the blood supply. Following the original Brennemark protocol, implants were buried below the tissue and left to integrate for 4 to 6 months before a second surgery to uncover and place a healing abutment, that is stage 2 technique. In the 1990s, a more conservative one-stage surgery technique became popular that involved placement of a healing abutment at the time of implant placement. This procedure showed remarkable results with decreased morbidity. Then, in the 2000s, immediate implant placement became popular, and advancements in guided surgery allowed the advent of flapless surgery, which resulted in much less trauma. With advanced technology, clinicians are now able to 3D print surgical guides in their office that are based on cone-beam computer tomographic imaging for ideal implant placement and accurate anatomy, which has led to more accuracy with flapless techniques. However, flapless surgery is not indicated in all cases and certainly may lead to higher morbidity. Therefore, it is imperative that the implant surgeon understand the basic principles of flap design. It has been shown that 3 essential factors are required to maintain and regenerate soft tissue quality with implant-related procedures. First one, preservation of the blood supply to the adjacent papilla. Second, preservation of the bone on the adjacent teeth. And third, minimal scar tissue formation during surgery. When soft tissue becomes rigid and non-flexible as a result of traumatic surgical manipulation or previous surgical interventions, it may not allow for ideal adaptation of flexibility around the dental implant or prosthesis. Types of flaps. Flapless. Flapless implant surgery has become popular because of the associated decreased pain and morbidity. In the flapless technique, a tissue punch is used to remove the gingival tissue over the osteotomy site. Mainly, this technique has been advocated because of the preservation of the blood flow to the papilla and decreased postoperative pain. Oliver has shown that flapless surgery is advantageous for preserving the crestal bone and is reduced when the gingival tissue is thick, that is greater than 3 mm. However, when performing flapless surgery, adequate bone quantity must be present along with sufficient keratinized tissue. The associated disadvantage of this technique is the inability to visualize the underlying bone. Cone-beam computer tomographic imaging and guided surgery have made flapless surgery more predictable. However, inherent errors still exist. In most flapless surgery cases, a tissue punch is used to expose the bone. The gingival tissue will be removed in the area of osteotomy. Care should be exercised in using a tissue punch when an inadequate amount of keratinized tissue is present. Flapless surgery has been shown to result in overheating the bone because it is often difficult to irrigate the osteotomy adequately when a flap is not raised. Papilla sparing. The interproximal soft tissue in sites next to adjacent natural teeth may be classified into 3 categories. First one, papilla have an acceptable height in the edentulous site. Second, papilla have less than acceptable height. Or third, one papilla is acceptable and the other papilla is depressed and requires elevation. When the interproximal papilla has an acceptable height, papilla saving incisions are made adjacent to each neighboring tooth. The full thickness incision then approaches the crest of the edentulous site, leaving 1 to 1.5 mm of the interproximal papilla adjacent to each tooth. This maintains the blood supply to the papilla and will help to preserve the papilla after healing. Flapless surgery Advantages: less invasive, maintains tissue vasculature, no vertical incisions, less patient discomfort. Disadvantages: limited visibility, overheating bone, limited access to evaluate bone, malpositioning is more common unless guided. Papilla sparing surgery. Advantages: no disruption of the papilla, less morbidity, minimal disruption of vasculature. Disadvantages: no access to additional sites, need additional skill set, minimal reflected space for implant placement, difficulty in bone grafting, possible scarring in non-keratinized tissue. Envelope flap surgery. Advantages: no vertical incisions, easy to suture, easy to modify. Disadvantages: limited access, moderate disruption of vasculature, increased risk for tension upon closure, guided bone regeneration not possible. Proper incision positioning. If there exists 3 mm or more of attached gingiva on the crest of the edentulous ridge, the incision should ideally bisect the soft tissue. This places half of the attached gingiva width on each side of the incision, that is 1.5 mm, thereby strengthening the incision line. If there is less than 3 mm of attached keratinized tissue on the ridge crest, the incision should be made more lingually so that at least 1.5 mm of attached tissue is placed to the facial aspect of the implant. This concept is especially important in the posterior mandible because attached tissue is required to prevent tension and pulling from the buccinator muscle. Osteotomes. An osteotome is a surgical instrument which is used to cut, expand or divide bone. There exist multiple types which are procedure specific. Pointed. It is designed for progressive circumferential or circular expansion, that is bone spreading of the alveolar ridges which are compromised in width, that is division B. Progressive osteotomes, to incrementally widen or expand bone before implant placement. Concave osteotomes are used to infracture the floor of maxillary sinus through the implant osteotomy. The concave tip retains bone graft material. Second one, convex. Convex osteotomes are used to raise the floor of the maxillary sinus after fracturing, that is SA2 technique. Figure 26.38 shows osteotomes. Figure A shows sinus osteotomes with adjustable stops. Figure B shows offset osteotomes to increase osteotomy diameter. Figure C shows straight osteotomes for bone spreading. And figure D shows clinical image of crestal bone graft using an osteotome. Suture qualities. Absorbable. Absorbable suture material allows for the convenience of no suture removal. These types of sutures undergo degradation and absorption in the tissues. Thus, the sutures do not have to be removed. There are two mechanisms of degradation of absorbable sutures: enzymatic breakdown or degradation by hydrolysis, that is PGA. Sutures derived from a biologic origin, that is plain and chromic gut, are digested by intraoral enzymes. Usually, these types of sutures lose their tensile strength quickly, that is within days of surgery, and are not ideal for dental implant procedures. Secondly, these sutures may break down even faster when the intraoral pH is low. A decreased pH may result from infection, medications, metabolic disorders or dry mouth. Trauma from suture removal may sometimes lead to incision line opening. Moving on to chapter 27, implant placement surgical protocol. Flap design. Prior to the placement of implants, the underlying bone and osteotomy site must be exposed for implant osteotomy preparation and insertion. Full thickness flap. The most common technique includes a mucoperiosteal flap, which may involve the buccal, lingual and crestal areas. Flapless. This technique does not reflect the crestal soft tissue. Instead, a core of keratinized tissue, that is the size of the implant crest module diameter, is removed over the crestal bone. The implant osteotomy is then performed in the center of the core of exposed bone. This protocol requires no sutures around the healing abutment after implant placement. The advantages of this technique include less discomfort, tenderness and swelling, which are usually minimal. The primary disadvantage of flapless approach is the inability to assess the bone volume before or during the implant osteotomy or insertion. Therefore, this technique should only be used when the bone width is abundant, that is greater than 7 mm. In addition, bone grafting needs and procedures cannot be precisely evaluated. The soft tissue around the implant site should be ideal in amount of attached keratinized mucosa because the soft tissue pouches over the bone site. not in a region related to the soft tissue. Often, the keratinized tissue is reduced on the buccal half of the ridge, and the tissue punch may inadvertently remove all the keratinized tissue on the facial aspect of the implant. Because the crest of the ridge is below the soft tissue, it is difficult to see lines on the drill to assess the depth of drilling. Therefore, stops on the drill are particularly beneficial. The clinician may have difficulty in assessing the location of the implant crest module in relation to the crest of bone because it is also below the soft tissue. And lastly, the interdental papilla may not be elevated with this technique. Therefore, the soft tissue drape should be ideal in volume of keratinized tissue both facial-lingually and mesiodistally. Surgical approaches. Freehand surgery. This may include the flap or flapless technique with the clinician placing the implant with the diagnostic information available, that is position of adjacent teeth, radiographs. Freehand surgery may include the use of non-limiting surgical templates which allow the surgeon the dimensional variability in implant location because the template will indicate the position of final processes. However, it will not specifically guide the placement of the implant. Guided. This type of surgery, which may be performed flap or flapless, guides the osteotomy from a digitally designed and printed surgical template. This type of surgery allows the highest level of precision and control because the implant position is dictated via a comprehensive three-dimensional evaluation of the anatomy. Guided surgery may be differentiated by the type of support of the template. Bone supported. The template rests on the alveolar bone and this technique requires the reflection of a full thickness flap. Tissue or mucosa supported. The template is supported by the soft tissue. This type of template is most commonly used with the flapless technique. Tooth supported. This is the most accurate technique and includes placement of the template directly on the natural teeth for support. Guided surgery may also be classified according to the amount of drill guidance. Pilot template allows guidance for the position and angulation for only the first drill in the surgical protocol. After the first drill, the osteotomy is completely freehand. Universal template. This type of template is compatible with all implant systems and allows for depth, position and angulation. However, the final osteotomy drill along with the implant placement is completely freehand. Fully guided template. Template that allows for depth, position, angulation and implant placement via the guide. Navigational directed surgery. Computerized navigation surgery has evolved from neurosurgical procedures into the field of dental implantology. This technique allows the clinician to precisely transfer a detailed pre-surgical implant plan to the patient. The clinician uses computerized navigation to adjust the position and angulation of the surgical drill according to the pre-surgical digital implant plan. The real-time imaging of the surgical drill allows for continuous updates on the positioning of the drill to avoid critical anatomic structures. Dental implant osteotomy preparation. Decreasing heat during osteotomy preparation. The heat generated during an implant osteotomy is related to the presence and temperature of irrigation, amount of bone being prepared, drill sharpness and design, time of preparation, depth of osteotomy, pressure on the drill, drill speed, and variation in cortical thickness, that is bone density. Bone cell survival is very susceptible to heat. Erickson has demonstrated that in animal studies, bone temperature as low as 3 degrees Celsius above normal, that is 40 degrees Celsius, can result in bone cell necrosis. Therefore, a conscious effort is made to control temperature elevation every time a rotary instrument is placed in contact with bone. Many dental implant preparation variables need to be addressed in understanding the reduction of heat during osteotomy process. Irrigation versus no irrigation. Although some authors have advocated implant osteotomy preparation without irrigation, the literature does not support it. Yacker and colleagues showed that without irrigation, drill temperatures greater than 100 degrees Celsius are reached within seconds of the osteotomy, and consistent temperatures greater than 47 degrees Celsius are measured several millimeters away from the implant osteotomy. Bennington and colleagues have reported that the osteotomy temperature may rise up to 130.1 degrees Celsius without irrigation after monitoring changes in bone temperature during the sequence of drilling for implant site preparation. To minimize heat generation, at least 50 milliliter per minute of cooled irrigation of sterile saline, that is 0.9% of sodium chloride, should be used as a profuse irrigant and is a critical factor in the osteotomy process. The more dense the bone, the greater the need for copious irrigation. Distilled water should not be used because rapid cell death may occur in this medium. The irrigant also may act as a lubricant and removes bone particles from the implant osteotomy site. The temperatures of the irrigant can also affect the bone temperature. Barak and colleagues reported that cooling the irrigation fluid to 10 degrees Celsius, no mean temperature change greater than 1 degree Celsius will occur. Therefore, placing the irrigation fluid into a refrigerator before implant surgery will help to prevent heat generation during implant placement. Graduated versus one-step drilling. The amount of heat produced in the bone is directly related to the amount of bone removed by each drill. For example, a 2 mm pilot drill generates greater heat than a 1.5 mm pilot drill. As a result, most manufacturers suggest that the first pilot drill should be approximately 1.5 mm in diameter. In a similar fashion, the amount of heat generated by successive drills is also directly related to the increase in drill diameter. For example, a 3 mm drill after a 2 mm drill removes 0.5 mm on each side of the drill. A 2.5 mm drill after a 2 mm drill only cuts 0.25 mm of bone on each side of the osteotomy. The smaller incremental drill size allows the clinician to prepare the site faster with less pressure and less heat generation. Drilling speed. The subject of drilling speed has become very controversial in implant dentistry today. Erickson and colleagues originally recommended drilling speeds of 1500 to 2000 rotations per minute with irrigation. Most recently in implant dentistry, the rotational speed of the drill has been suggested to be less than 2000 rpm and several manufacturers have recommended speeds as low as 50 rpm. Kim and colleagues suggested drilling osteotomies at 50 rpm without irrigation and stated that the bone temperature may not significantly increase. However, Yeniol and colleagues showed that excessively low drilling speeds, that is less than 250 rpm, increased the degree of fragmentation of the osteotomy edge. It has been shown that low speed drills will wobble, which leads to over-preparation of the osteotomy site. The slowest rotations per minute resulted in bone temperatures at or greater than 40 degrees Celsius, which may be a threshold of bone cell death. The highest rotations per minute, 2500, increased the bone temperature by 2 degree to 3.5 degrees Celsius, whereas the 1225 rpm recorded a bone temperature greater than 41 degrees Celsius. Therefore, the highest speed of 2500 rpm may prepare bone at a lower temperature than 1500 rpm, especially when in dense bone. The rotational speed of the drill is one of the more critical criteria to reduce bone temperatures. Drilling time. Erickson reported bone cell death when a temperature of 40 degrees Celsius was applied for 7 minutes or when a temperature of 47 degrees Celsius was applied for 1 minute. Therefore, to reduce the preparation time within the bone to a minimum in D1 bone, the clinician should not apply constant pressure to the drill but bone dance with intermittent pressure for 1 second in the D1 bone and 1 to 2 seconds out of the bone while the cooled irrigation is allowed to perfuse the site. In summary, in D1 and D2 bone, a higher speed, that is 1500 to 2000 rpm should be used in the preparation of bone. In poorer quality bone, example D3 and D4, drilling speed is not as crucial. Therefore, a lower speed may be used, that is approximately 1000 rpm. Intermittent versus continuous drilling. When constant pressure is applied, irrigation cannot enter the osteotomy site. Therefore, this may result in heat-related damage. When intermittent drilling or bone dancing, that is continuously bringing the surgical burr in and out of the osteotomy site, less heat generation is seen. By bringing the burr in and out of the osteotomy site, irrigation may enter the site along with allowing any debris to be removed, thus making the cutting process more efficient. Insertion torque. The insertion torque, IT, is the force used to insert a dental implant into a prepared osteotomy. The amount of torque is expressed in units of Newton centimeters, which ultimately determines the loading protocol. Insertion torque is the primary most important factor in determining primary stability, with higher torque values leading to higher primary stability. Lower values of insertion torque have been shown to be associated with implant failures. Many studies have indicated insertion torque near the range of 35 to 45 Newton centimeters to be ideal for implant integration. To standardize the amount of torque, calibrated torque wrenches, physiodispenser instruments with integrated electronic torque control settings, and preset torque settings on the implant electrical motor systems should be used. Generic osteotomy preparation summary. Irrigation with copious amounts of 0.9% of sodium chloride. Irrigation solution temperature, refrigerate before use. Drilling technique, graduated protocol, that is more drills. Intermittent, that is bone dancing. Drilling speed, D1, D2 bone is 1500 to 2000 rpm. D3, D4 bone is approximately 1000 rpm. Drilling time, greater heat generation. Drilling pressure, minimize pressure, never allow rotations per minute to decrease from excess pressure. Insertion torque, 35 to 45 Newton centimeters. Misch developed a different surgical protocol for different bone qualities in 1988. The Misch classification of bone density includes 4 classifications: D1, D2, D3 and D4, which are based on the amount of cortical and cancellous bone. D1 bone is primarily composed of dense cortical bone and found mainly in the anterior mandible with basal bone. D2 bone has dense to porous cortical bone on the crest and within the bone has squamous trabecular bone. D3 bone types have a thinner porous cortical crest and fine trabecular bone in the region next to the implant. D4 bone has almost no crestal cortical bone. The fine trabecular bone composes almost all of the total volume of the bone next to the implant. Box 27.3 shows Hounsfield unit numbers related to bone density. D1 greater than 1250, D2 850 to 1250, D3 350 to 850, D4 0 to 350. Osteodensification. A new method of implant preparation termed osteodensification has recently been introduced to implant dentistry. Huveis and colleagues in 2013 introduced a surgical protocol that includes the use of special densifying burrs which resulted with low plastic deformation of the bone. The specially designed burrs, denser burrs, result in bone densification as the osteotomy is prepared, thereby increasing bone at the implant interface. The denser burrs utilize the concept of osteotomes along with drilling speed to laterally compact bone during preparation. Bone is preserved and condensed through compaction autografting, increasing the bone density and improving the mechanical stability of the implant. Conventional surgical drills excavate bone during implant osteotomies, which requires approximately 12 weeks of bone remodeling to repair. Because the osteodensification protocol preserves bone while increasing density, the healing time may be shorter. Other methods of osteodensification by use of undersizing the drills has been established. Degidi and colleagues showed a significant increase in primary stability by decreasing the preparation size by 10%. Generic drilling sequence. Step 1. Pilot drill. With most surgical systems, a 1.5 mm or 2 mm surgical pilot drill is used to initiate the osteotomy. Pilot drills are end-cutting starter drills used to most commonly initiate an osteotomy in the center of the ridge in a mesiodistal and buccolingual dimension. Step 2. Position verification. Usually, a director indicator, that is depth gauge, which corresponds to the initial bud diameter, is then inserted into the osteotomy and the angulation and position assessed. Step 3. Second twist drill. The second drill used is approximately 2.5 mm in diameter and is an end-cutting twist drill required for the initial osteotomy to the required depth. The osteotomy location and angulation are reassessed at this point. A slight correction of position or angulation with a Lindemann drill may be completed. However, it should ideally be accomplished after the first drill. Step 4. Final shaping drills. Depending on the surgical system used, most shaping drills are used to sequentially widen the osteotomy to the matching diameter of the implant being placed. Depending on the diameter, multiple twist drills may be used. The desired depth along with the ideal location and angulation of the osteotomy should be verified. Most important drill kits will clearly identify the drill sequence and final osteotomy diameter related to each diameter implant. Usually, the final drill will be within 1 mm of the final diameter of the implant diameter. That is, a 4 mm implant will have a final drill size of approximately 3.2 mm. Step 5. crest module and bone tap drills. Most implant crest modules, that is implant neck, are larger in diameter than the implant body. The larger diameter often requires a side-cutting crest module drill in D1 and some D2 crestal bone situations to prepare the crestal aspect of the implant osteotomy. This drill is not recommended when the bone density is poor, that is D3 and D4. Figure 27.13 shows final shaping drills. Final drills used to widen the osteotomy to accommodate the diameter of the intended implant. Figure 27.14 shows tap drill, which is used mainly in D1 bone at approximately 30 rpm. Step 6. Implant insertion. The implant site may then be prepared for implant insertion. The osteotomy is lavaged with sterile saline and aspirated to remove bone debris and stagnant blood. This reduces the risk of these materials being forced into the bone marrow spaces or neurovascular channels during implant insertion, causing hydrostatic pressure. This pressure may increase the D-vital zone of the bone around the implant or even cause short-term neurosensory impairments when the implant site is in the vicinity of mandibular canal. The implant may be inserted with a hand ratchet or handpiece. The advantage of inserting an implant with a handpiece is that the placement will be more ideal and deviation is less likely, especially in poorer quality of bone, example D3 and D4 bone. However, in better quality of bone, especially D1, difficulty in insertion may sometimes occur. When placing an implant with a hand ratchet, good apical pressure should be used to decrease the possibility of deviating the path of the implant. If the implant is tightened onto the osteotomy and significant stress occurs at the crestal area, pressure necrosis may occur and an increase in the D-vital zone of bone around the implant during healing will occur. If this should occur, the implant may be unthreaded 1 to 2 mm and then reinserted back into the osteotomy. When the implant is placed into the final position, a post-insertion periapical radiograph is taken to verify ideal positioning. Dental implant surgical protocol 1. For D1 bone, dense cortical bone. Advantages of D1 bone. The homogeneous, dense D1 bone is highly mineralized and able to withstand higher occlusal loads. The cortical lamellar bone may heal with little interim woven bone formation, ensuring excellent bone strength while healing next to the implant. The percentage of light microscopic contact of bone at the implant interface is greater in D1 bone type and greater than 80%. In addition, this bone density exhibits greater strength than any other bone type. The strongest bone also benefits from the greatest bone implant contact. Because of the density of this bone, less stress is transmitted to the apical third of the implants than in other bone types. As a result, shorter implants can better withstand greater loads than in any other bone densities. In fact, the placement of longer implants may decrease surgical survival rates because overheating during osteotomy preparation is a primary concern in this bone type. Greater heat is often generated at the apical portion of the osteotomy, especially when preparing dense cortical bone. Disadvantages of D1 bone. Increased crown implant ratio, poorer blood supply, overheating the bone. Box 27.4 shows D1 bone disadvantages. Bone necrosis, prevention, final implant placement at or above bone level, unthread half turn to relieve internal stresses. Decreased blood supply, prevention, primarily from periosteum, increased healing time, minimal reflection. Should use bone tap, prevention, decreases pressure necrosis, allows passive implant fit, prevents internal implant body, implant bone interface microfracture, removes drill remnants. Overheating during osteotomy, prevention, new drill designs, fluids, geometry, abundant external irrigation, intermittent pressure on drill, that is bone dancing, pause every 3 to 5 seconds, keep irrigating. Incremental drill sequence, that is more drills, pass same drill more than once to widen osteotomy in preparation of next drill. On the other hand, because of the load-bearing capability of D1 bone and the excellent bone implant contact, prosthetic loading of D1 bone may start before the completion of the initial healing phase. Conditions that contribute to a lack of movement during healing are primordial to achieve a direct bone implant interface. D1 bone is strong and often able to resist micro movement regardless of whether an implant is loaded. As a result, immediate implant loading is often possible when multiple implants are splintered together without compromise to the overall survival rate of the implant. However, most often, a blend of treatment conditions result in a minimum 3-month unloaded healing period in this bone type. Dental implant surgical protocol 2 for D2 bone, dense to thick porous cortical and quasi-trabecular bone, D2. The second density of bone found in the edentulous jaws, D2, is a combination of dense to porous cortical bone on the crest and quasi-trabecular bone within the cortical plates. Advantages of D2 bone. D2 bone provides excellent implant interface healing and osseointegration is very predictable. Therefore, it is the ideal type of bone. There exist no disadvantages in D2 bone. Most implant systems refer to this density of bone for the generalized surgical protocol. The dense to porous cortical bone on the crest or lateral portions of the implant site provide a secure initial rigid interface. The implant may even be placed slightly above the crest of the ridge with decreased compromise or risk of movement at the interface during healing compared with softer bone types. The intrabony blood supply allows bleeding during the osteotomy, which helps control overheating during preparation and is most beneficial for bone implant interface healing. Implant osteotomy surgical sequence. A bone tap most often will lead to a decreased primary stability in D2 bone. A crestal bone drill should be used for most implant designs in D2 bone. The osteotomy preparation should proceed at a higher speed, example approximately 2000 rpm. The implant may be threaded into position with a low speed, that is less than 30 rpm, high torque 75 Newton centimeter, handpiece rather than using a hand ratchet. Healing. The excellent blood supply and rigid initial fixation of D2 bone permits adequate bone healing within 4 months. The lamellar bone implant interface is more than 60% established at the 4-month healing interval. Bone implant contact is approximately 70% at this point in time, especially when cortical bone engages the lateral and lingual portions of the implant. Dental implant surgical protocol 3. D3 bone, thin porous cortical and fine trabecular bone. The CBCT reformatted images may have a range of 375 to 750 Hounsfield units. This bone quality provides the clinician with a tactile sense similar to drilling in compressed balsa wood. The trabeculae are approximately 50% weaker than those in D2 bone. D3 bone is found most often in the anterior maxilla and posterior regions of the mouth in either arch. It may also be found in the division B edentulous ridge modified by osteoplasty to provide adequate width for a root form implant placement. Sinus augmentation grafts are often D3 bone in the posterior maxilla after a healing period of 6 months or more. Advantages of D3 bone. The main advantage of D3 porous, compact and fine trabecular bone is that the implant osteotomy preparation time and difficulty is minimal for each drill size and is usually less than 10 seconds. The crest module drill and bone tap may be eliminated in the surgical protocol. Blood supply is excellent for initial healing and intraosseous bleeding helps cool the osteotomy during preparation. As a result, this bone density is usually associated with a high surgical survival rate. Disadvantages of D3 bone. D3 bone also presents several disadvantages. It is more delicate to surgically manage than the previous 2 bone density types as its preparation takes minimal effort. The motor speed in drilling the osteotomy is not as important as in D1 or D2 bone. Therefore, bone preparation in D3 bone can range from 1000 to 2000 rpm and must be made with constant care of direction to avoid enlargement or elliptical preparation of the site. Box 27.7 shows disadvantages of D3 bone. Bone implant contact, approximately 50%. Longer healing period, additional implants recommended. Implant placement, 1 chance widened osteotomy. Thin crestal cortical bone which decreases primary stability. Greater risk of overload during healing. Box 27.8 shows D3 bone surgical protocol. Under preparation. No last burr, that is osteodensification. Drilling speed 1000 to 2500 rpm. Speed not as important in poor quality bone. Final drill and bone tap not used. Irrigation using copious amounts of saline. Bone dance not as critical in comparison to better quality bone. And implant placement using handpiece. Dental implant surgical protocol 4. D4 bone. Fine trabecular bone. The most common locations for this type of bone are the posterior molar region of a maxilla in the long-term edentulous patient or in an augmented ridge in height and width with particulate bone or substitutes or in a sinus graft. Disadvantages of D4 bone. Fine trabecular bone presents the most arduous endeavor to obtain rigid fixation. Bone trabeculae are sparse and as a result, initial fixation of any implant design presents a surgical challenge. Additional implants are placed to improve implant bone loading distribution and prosthodontic rehabilitation, especially during the first critical year of function. For fixed restorations, no cantilever on the prosthesis is used with this bone density. Healing. The healing and progressive bone loading sequence for D4 bone require more time than the other 3 types of bone. Primary stability. Accurate assessment of primary stability is crucial in the implant placement protocol. Methods of measuring implant stability include percussion testing, insertion torque, reverse torque testing, resonance frequency analysis RFA, and surgical experience. Perio test. In the early days of implantology, instrumented percussion testing used the Perio test system. Perio test evaluations have been used to gauge primary stability. The system is composed of a metallic tapping rod in a handpiece, which is electromagnetically driven and electronically controlled. Signals produced by tapping are converted to unique values called Perio test values. These results are expressed in arbitrary units with acceptable Perio test values in the ranges of -4 to -2 and -4 to +2. However, today this device has been supplanted by resonance frequency analysis because of the lack of reproducibility of the results derived from Perio test measurements. Resonance frequency analysis. In implantology today, the more common method of determining primary stability is resonance frequency analysis RFA. RFA is a testing method that provides objective and reliable measurements of lateral micromobility at various stages of the implant treatment process. The method analyzes the first resonance frequency of a small transducer attached to an implant or abutment. It can be used to monitor the changes in stiffness and stability at the implant tissue interface and to discriminate between successful implants and clinical failures. The implant stability quotient ISQ is the scale of measurement for use with the RFA method. 1 stage versus 2 stage. The clinician is often confronted with the choice of completing the dental implant procedure with a 1 stage or a 2 stage protocol. Numerous studies have shown no difference in success rates between the two techniques. 2 stage surgery. The 2 stage surgery technique involves the placement of the implant and a low profile cover screw which is inserted into the implant body. When the cover screw is in final position, it may be slightly tightened, loosened and tightened again. No tissue, blood coagulants or bone particles should prevent the complete seating of the cover screw. 1 stage surgery. A 1 stage surgical protocol involves the placement of a healing abutment that extends slightly above the crust of the tissue. The soft tissue is then sutured around the healing abutment to form a soft tissue drape during the healing period. Moving on to chapter 28, Ideal Implant Positioning. Box 28.1 shows non-ideal implant positioning complications. Increased implant mobility, increased prosthetic complications, example aesthetics, prosthesis, increased prosthetic cost, example implant parts, laboratory costs, increased peri-implant complications, decreased longevity of prosthesis, less patient acceptance. The ideal 3-dimensional positioning of a dental implant needs to be addressed before the surgical procedure. Lack of proper planning may lead to malpositioning, which may be evaluated in the 3 spatial planes. The placement of a dental implant in available bone is comparable to an object in space that is defined by X, Y and Z coordinates. In implant dentistry, the X-axis is defined by the mesodistal plane. The y-axis is the buccolingual dimension and the z-axis is known as the apicocoronal, that is length of the implant body in relation to the osseous crest. Unfortunately, many dental implants are placed within the existing available bone without respect to the three dimensions. In this chapter, the proper positioning of implants will be discussed according to the final prosthetic needs and demands of the patient and the treatment protocols for implants that are placed in non-ideal positions. X-axis, mesial distal positioning. Insufficient implant tooth distance, apical. Ideal positioning. Ideally, it is best to allow at least a minimum of 1.5 mm from the adjacent tooth root or tooth structure. Maintaining this amount of space from a tooth root decreases the possibility of causing damage to the tooth and postoperative complications. Because of the close proximity of implants to an adjacent tooth, the implant may fail because of infection or bone resorption. If less than 1.5 mm of space exists between the implant and the root apex, then the periodontal ligament may be damaged, which can result in irreversible trauma and internal or external resorption of the natural tooth. Therefore, placing an implant too close to the root surface may ultimately lead to implant or tooth loss, which can occur in the short term or the long term. Treatment. Initial placement. If there is insufficient space between an implant and the root apex after initial placement, then the implant should be removed and repositioned, especially if the adjacent tooth becomes symptomatic. If available space is compromised, then the roots should be repositioned via orthodontics or the treatment plan changed to a different type of prosthesis. Pass placement. If an implant has been restored and root approximation less than 1.5 mm exists, then the tooth or implant should be monitored on a more stringent clinical and radiographic recall basis, along with informing the patient of possible morbidity. The patient should be made aware of the proximity and possible complications that may result. If symptomatic or radiographic pathology is present, then the implant should be removed and repositioned along with vitality testing of the tooth. Box 28.2 shows lack of space between tooth or implant, apical. Complication: tooth hypersensitivity, loss of tooth vitality, periapical pathology, tooth loss, implant loss. Prevention: ideal positioning, that is greater than 1.5 mm. Accurate radiographic evaluation, that is CBCT. Diagnostic wax-up or interactive treatment planning. Treatment: pre-prosthetic, remove implant, check tooth vitality. Post-prosthetic, strict recall evaluation, monitor tooth vitality. Prevention: a common technique to avoid placing implants too close to a tooth is the use of a surgical template. A pilot, universal or fully guided surgical template may be used that will prevent the implant from being placed too close to the tooth. In addition, if a template is not used, there exist multiple positioning devices that allow for ideal osteotomy positioning, that is 1.5 to 2 mm from the adjacent tooth. A surgical spacer may be used which enables the initial osteotomy site to be placed at the correct position, allowing for adequate space between the tooth and final implant position. Surgical guidance systems, Salvin, Charlotte, North Carolina, also may be used to ensure ideal implant placement, that is buccolingual and mesiodistal spacing, and may be used with any surgical drill system. However, the most accurate positioning adjunct is the use of CBCT generated surgical templates, that is tooth supported. Lack of implant to implant distance. Ideal positioning. The distance between two implants has been determined to be a significant factor with respect to crestal bone loss, the presence of inter-implant papilla, and generalized tissue health. Ideally, there should exist 3 mm or more space between any two adjacent implants. Box 28.4 shows excessive space between tooth implant. Complication: over-contoured crowns, atypical prosthetics, cantilever effect, that is biomechanics, food impaction, periodontal complications. Prevention: ideal positioning, that is 1.5 to 2 mm from tooth. Accurate radiographic evaluation, that is computerized tomography. Diagnostic wax-up or interactive treatment planning. Parallel long axis of adjacent tooth. Use of a surgical template. Treatment: minimal occlusal forces, narrow occlusal table, minimal cusp height, no lateral contacts, that is cantilever, over-contoured crown. High occlusal forces, over-contour adjacent tooth, reduce mesiodistal distance, remove implant and reposition. Complications. When lack of interproximal bone, that is less than 3 mm, is present, a decreased blood supply will result, eventually leading to bone loss. Tarnow and colleagues have shown that implants placed less than 3 mm apart may have adequate stability and function. However, this placement will likely result in crestal bone loss. In this study, implants with a greater than 3 mm distance between implants resulted in a 0.45 mm bone loss, whereas implants positioned less than 3 mm had over twice the amount of bone loss, or approximately 1.04 mm. Buccolingual positioning, y-axis. The faciopalatal or buccolingual positioning of the dental implant is crucial to the aesthetic and biomechanical effectiveness of the final prosthesis. Frequently, implant positioning is dictated by the resulting available bone, leading to angulation complications. Bone remodeling after tooth extractions is common, with resorption occurring from the buccal plate initially, decreasing the width of the bone and shifting the ridge position more lingual. When evaluating the faciopalatal positioning, two dimensions need to be investigated. First one, faciopalatal ridge position. Second, faciopalatal angulation position. Ideal positioning, faciopalatal angulation. One area that faciopalatal positioning is most critical is the maxillary anterior region because of the inherent angulation issues, that is, trajectory of the natural teeth with respect to the available bone. Coupled with being in the aesthetic zone, there is very little room for error when placing implants in this area. In the literature, 3 different protocols for the buccolingual or faciopalatal angulations of the implant body have been discussed. First one, similar to the facial position of the adjacent natural teeth. Second, under the incisal edge of the final restoration. And third, within the cingulum position of the implant crown. Facial implant body angulation, anterior. However, the facial crown contour of a natural tooth has 2 planes and its incisal edge is palatal to the facial emergence of the natural tooth by 12 to 15 degrees. Faciopalatal positioning. Angulation with respect to prosthesis type. Figure 28.35. A and B shows ideal implant placement for a cement and screw retained prosthesis in the anterior. C and D shows ideal posterior implant placement in line with the adjacent teeth central fossas. Screw retained anterior. For screw retained prosthesis in the anterior, the implant should emerge within the cingulum area of the anterior tooth, so the access hole does not affect the aesthetics of the restoration. If the implant is placed too facially, then the access hole will impinge on the aesthetics of the restoration, that is, screw hole through the facial of the restoration. If the implant is placed too far lingually, over-contouring of the final crown may result in biomechanical issues and possible occlusal interferences. Posterior region, cement retained or screw retained. In the posterior region, the long axis of the implant should emerge within the approximate center, that is central fossa of the prosthesis for a screw retained or cement retained FP1 or FP2. This allows occlusal forces to be directed ideally along the long axis of the implant. Apicocoronal Z-axis. The depth of implant placement in the bone is a significant factor in relation to the longevity of the implants. Whether the implant is placed too deep or not apical enough, prosthetic and periodontal complications may increase implant morbidity. Ideal positioning. In most regions of the mouth, it has been suggested that the implant platform be placed approximately 2 to 4 mm apical to the adjacent cemento-enamel junction or free gingival margin. In conclusion, the ideal anterior and posterior implant body position is 2 to 4 mm below the facial free gingival margin of the adjacent teeth. The depth of an implant platform greater than 4 mm below the adjacent CJ is too deep. An implant platform position less than 2 mm below the free gingival margin of the crown is too shallow. Therefore, the ideal depth position of the implant platform is more than 2 mm and less than 4 mm below the free gingival margin. Excessive depth. Some authors have suggested that the implant be deepened, that is countersunk below the crestal bone more than 4 mm below the facial CJ of the adjacent teeth to develop a crown emergence profile similar to a natural tooth. This provides a subgingival emergence transition of about 5 mm on the facial aspect to achieve the width of the natural tooth. When the implant is countersunk below the crestal cortical bone, as with this depth technique, the trabecular bone around the crest module is weaker against the occlusal loads. In addition, when the implant is placed below the crestal bone, the resultant initial crown height is increased, as are moment forces. An increased risk of additional bone loss also is present from the increased moment loads applied to weaker trabecular bone, which may also result in soft tissue shrinkage over the long term. The end result is longer clinical crowns, which also decrease gradually in width as the narrowing dimensions approach the implant body. The interproximal region may result in black triangular spacings in lieu of interdental papilla. The increased crown height also increases forces to the abutment screw and increases the risk of screw loosening. FP1, FP2 and FP3. Placement too deep. When implant placement results in positioning deeper than 4 mm below CEJ or free gingival margin, many complications may result. First one, unfavorable crown height space, CHS, crown to implant ratio. Second, periodontal complications because of the inability to perform proper hygiene and associated bone loss on adjacent teeth. Third, higher moment forces which cause biomechanical overload with resultant crestal bone loss. Fourth, prosthetics are more complicated with difficulty in impression taking, placing abutments and seating the prosthesis. Fifth, with deeply placed implants, often the facial plate will resorb, especially if facial inclination is present. Sixth, long-term circular health is decreased because there is minimal to no cortical bone present. The trabecular bone around the crest module is weaker against occlusal loads. Seventh, resultant initial crown height and moment forces are increased. A further increased risk of soft tissue shrinkage occurs in long term with additional bone loss at the crest module. The result is longer clinical crowns which also decrease gradually in width as the narrowing dimensions approach the implant body with resultant black triangular spacings in lieu of interdental papilla and compromised long-term aesthetics. The following may occur when implant positioning is not deep enough, that is less than 3 mm from CEJ and less than 2 mm from free gingival margin. First one, inadequate emergence profile, that is transition from the narrower diameter of the implant compared with the wider dimension of the crown. Second, decreased retention of the implant which may lead to uncementable restorations or component fracture. Third, poor resultant aesthetics because implant abutment or implant body will show through, resulting in cervical darkness, and if this occurs in the anterior region, it may be unpleasant for the patient. Normally, the facial margin of the crown will not be able to be placed subgingival enough to mask the titanium color of the abutment below the margin. Fourth one, inadequate running room because the location of the crest module will leave inadequate room for adequate hygiene. An abrupt change from the prosthetic platform to the diameter of the restoration will result. Normally, this will most likely result in hygiene difficulty. RP4 and RP5. When evaluating a treatment plan for a removable implant prosthesis, numerous factors need to be addressed. First, it must be determined that adequate interocclusal space is present, especially if a connecting bar is to be utilized. For a bar and overdenture with attachments, 15 mm of space is required from the crest of the ridge to the incisal edge is suggested. If interocclusal space is insufficient, then an osteoplasty at the time of surgery should be completed to increase space for the final prosthesis. Interactive treatment planning may be used to fabricate a reduction guide which will allow the implant clinician to remove the ideal amount of bone. A minimum of 2 mm of acrylic is required to adequately retain denture teeth and maintain structural integrity of prosthesis. Use of CBCT surgical guides. To overcome the limitations and complications inherent with conventional surgical templates, the use of CBCT generated templates has evolved in implant dentistry today. A computer generated surgical guide, partial limiting or complete limiting, provides a link between the CBCT treatment plan and the actual surgery by transferring the interactive plan accurately to the surgical site. Summary. One of the most critical skills in the practice of implant dentistry is the ability to place an implant in the ideal and correct position. The complexity of this skill set is underrated. The clinician needs to understand the three planes of placement along with maintaining a safe distance from vital structures. Malpositioning may result in a successful integration of the implant, but it may place the intended restoration at significant risk for complication or failure. Technological advances such as guided surgery and surgical templates have proven to be helpful to the implant clinicians, especially those early on their surgical learning curve or in cases in which space tolerances are low. However, even these techniques have margins of error and tolerances that need to be fully understood. With a combination of proper treatment planning and ideal positioning guidelines, the implant clinician can ensure a predictable surgical and prosthetic outcome. Thank you.